Mama, hormone replacement therapy, or HRT, is a method many women use for relief of menopausal symptoms such as hot flashes, anxiety, and vaginal dryness. And yet, there is still a fair amount of confusion and more than a few questions on the topic of HRT. Is HRT safe, and for whom? What is the duration of treatment, and how do we resolve between the facts and the fiction that surround this therapy? Today, I am so very fortunate to have with me an expert who can help us unravel some of these questions. Peter Koshland is with us today. Peter Koshland, PharmD, is a graduate of Georgetown University, class of 1996, and the University of California at San Francisco School of Pharmacy, class of 2000. Peter opened his compounding pharmacy, Koshland Farm, in 2009 in San Francisco, and has continued to work with doctors and patients on individualized and integrative therapies that make a difference in the quality of patients' day-to-day lives. He trains and consults with doctors across the state of California in the areas of hormone replacement, thyroid disorders, and compounding applications for dermatology, urology, and pain management. Peter, welcome. How are you today?
Thank you. I'm doing great, and you're giving me a chance to talk about my favorite subject in the world, so I'm happy to be here.
Yes. Yes. And I'm so happy that you are here with us and eager to share what some of the things are that dispelling the myths and just getting the word out about hormone replacement therapy. The myths and the madness.
Yeah, that's a good one. Still, after all this time.
Yes.
So.
Oh my goodness. So for those who may not know, what is a custom compounding pharmacy and how does it differ from a traditional pharmacy?
Yeah, I mean, we are a regular pharmacy in the sense that we get a prescription for a patient, and we dispense that medication to you as you would at any pharmacy, with a pharmacist there to, advise you how to best to use it. The only difference is what happens in between those two steps, which is at our pharmacy, that medication is actually being custom made by some technicians from kind of bulk raw ingredients. And it's basically individualized therapy. It's a very personalized therapy that would be for that individual. And it allows us to do some things that you just can't do at a regular pharmacy. We can create different dosages, dosage forms that you can't get. There are actually in the hormone world, there's some hormones that are quite valuable that aren't available at a regular pharmacy that we have access to that we can use. So, there's just an opportunity to kind of expand what you can get from your typical Walgreens or CVS and really make it for that specific patient, exactly what they need.
Oh, that's perfect. And now, can you also speak on the differences between natural, synthetic, and bioidentical hormones?
Yeah. There's a huge confusion around that.
Yes.
They seem to be bioidentical. I mean, the easiest explanation for bioidentical, and I think that word trips people up, and the regulators don't like it because it's like they call it a marketing term. But at the end of the day, what it really is trying to say is we're going to give you a hormone that's identical or biologically identical to what your body makes. Mm-hmm. And the rationale behind that is that, your body knows how to utilize those hormones. We know generally how much your body produces when you're producing hormones at that age. And we know how the hormones kind of get metabolized and eliminated from the body. So the philosophy around that is that that's going to be the safest and most appropriate way to give people hormone replacement. And what we found is that the research really bears that out. When we give people other non-bioidenticals or synthetic hormones, the side effect profile, the safety profile changes quite dramatically, actually. So that's really the bioidentical in a nutshell. Synthetic versus compounded versus commercial. you can get bioidentical hormone replacement from your CVS or Walgreens. There are some products that are available from a manufacturer, from a pharmaceutical company.
Oh,
They're,
really?
yeah, so it doesn't have to be compounded. That's kind of a misnomer that it always has to be compounded. Your options are a little more limited, and there's some other considerations about how you would get that. But for me, getting anybody on a good hormone replacement, however they get that, is a good thing. We don't want people to be on these more dangerous synthetic hormones. So whether it's going to be from us, that's something more custom and compounded, or from your regular pharmacy, we just want to make sure people get the hormones that we know are safe and are going to be the most effective.
Oh, that's wonderful. Now, with regard to the compounding hormone replacement, what is that, and what are the similarities and the differences between it and the FDA-approved hormone therapy, hormone replacement?
There's no difference, really.
Okay.
The FDA approval process, so the pharmaceutical industry loves to slander our industry. I think, as you know, they're competition, so I get that. They use whatever tools they can, but we're really a retail pharmacy. We're not manufacturing drugs. So the FDA approval process is really for drug manufacturers that are making huge quantities of a single formulation and distributing it across the entire country with lots of paperwork and research behind it. We're really more curated. I mean, we're a pharmacy that has a relationship with the doctor and the patient, and we're really trying to talk to both of those people and find out what's best for them, like based on the expertise and the knowledge of the doctor, and based on the feedback and kind of symptom presentation of the patient. So it's a quite different, and for that reason, we're not really an FDA approved product, because we're really more of a prescription item that's for an individual. So it's the hormones that we're using, the philosophy and the research that we're using to justify all of our decision making is the same. It's just one's going to be this kind of very personal formulation based on that relationship, versus kind of the more mass produced option.
Got you. Okay. Now that we've gotten that out of the way, let's just talk about some of the down and dirty stuff. When a woman is in perimenopause, her hormones are all over the place, and I like to refer to it as puberty in reverse. So how does hormone replacement benefit her initially?
Well, the goal with hormone replacement in a perimenopausal woman is primarily quality of life stuff. So, this is where the individualization and having that relationship with the patient really comes in handy, because women present very, very differently through perimenopause. Some it's kind of not such a big deal, and some it rocks their world, and in different ways. So it's a matter of looking at, do you have hot flashes? How many? How severe are they? Night sweats. Brain fog's a really big one that comes up, especially for professional women who have difficulty concentrating. So it's important to start there and to kind of see what's happening, with you. What are the symptoms? How long have you had them? How are your cycles? Are they starting to become irregular? And then utilizing the hormone replacement to really address that kind of chaotic hormone milieu that's happening for those years in the transition. And our goal is always total resolution of symptoms. So it's not like we just hope to make it, shave off the edges and make it tolerable. I really think with good hormone replacement, our goal should always be to achieve zero hot flashes, zero night sweats, total reduction of brain fog, all of that kind of stuff. So really,
that's possible.
It is very possible. Now, do we always get there with every patient? No, but we can get very close if we don't get there. But that's really what we shoot for. So we want to set those expectations that, we're going to have to kind of do some work around this, and I know a lot of the work you do is around nutrition and lifestyle. That is essential for the success of the hormones to work. And we have to kind of make sure we get that right balance of the different hormones that we're going to give women as well. So
excellent. Wow. So most often when hormone therapy is discussed, only estrogen is mentioned. So can you speak to the role of progesterone and why it's important?
Yeah. I love progesterone. I've trained hundreds of doctors in hormone replacement, and I always say, if you're intimidated by this therapy and you're not sure where to start, always give your patient progesterone, because they're going to be deficient. Progesterone is only produced by the ovaries. So when women go through menopause, progesterone always drops. Estrogens can be produced in some other tissues. It's primarily from the ovaries, but they tend not to drop. It tends not to drop as much. So why do I always say give them progesterone? Because the way the body utilizes hormones is really in, the elegant way to say it is like in a symphony with the other hormones. So progesterone, estrogen, and even testosterone in women all kind of work together to help shore up the women's body and functioning and all of that kind of stuff. Right. So if we're just focused on estradiol, and estradiol is extremely important, I don't want to say that it's not, but we're only looking at like one instrument in the symphony. We're only
right.
We need some other instruments to make the symphony sound beautiful. And progesterone oftentimes in kind of the more allopathic world gets kind of overlooked. It's really seen as more of like, well, it's protective, so the patient doesn't get endometrial cancer. But the way we see progesterone in the functional world is progesterone has all these other benefits. It's utilized in every system in the body where estrogen is utilized. So that is the brain, the muscle, the bone, everywhere, urinary system. And if progesterone is not adequately present in the body, estrogens don't work well. So you need both for both to work well. And it's really wonderful for some of the key symptoms that we see patients present with, specifically mood stuff and sleep. So oftentimes what we'll hear is, I got my progesterone capsules and I finally had a full night of sleep, restful sleep for the first time in years. And how powerful that is. I mean, sleep is, as you know, one of the key elements to healthy lifestyle.
Oh, so my God, yes.
Be very, very impactful. So yeah, we just want to make sure that people are seeing progesterone for what it is, which is a key element to the hormone replacement regimen, the complete regimen. And it's very helpful, yeah.
Oh, that is, oh my gosh, progesterone. I love you. Well, now we have a question. We have a question from Callie. She says, I've been wanting to get into hormone therapy as my autoimmune disease has a pattern of flaring up around my cycle, but I only see hormone therapy treatments linked to menopause.
Yeah.
So can you speak to that?
And it speaks to something that I always bring up, is that anytime a woman has symptoms related to their cycle, we should be thinking hormones, because that's really, that's what's happening when you cycle. Your hormones are having different fluctuations, especially if you're premenopause, and so you're having regular cycles. So, patients getting premenstrual migraines or other symptoms that happen kind of either before menses or some other time during the cycle, but kind of on a regular cadence with the cycle. Hormones should be looked at as a potential opportunity to kind of shore up that hormone balance, because we talk a lot about peri and postmenopause, and hormone has a huge role there, but we work with a lot of premenopausal women who have hormone imbalances even though they're still cycling. Again, going back to progesterone, sometimes that estrogen progesterone balance is not adequately balanced out in the later stage of the cycle. So looking at kind of how those two hormones kind of cycle through the 28 days or whatever the length of the cycle is, can be a really great way to kind of start looking at the underlying kind of hormonal milieu that might be contributing to some of these cyclic symptoms. So definitely worth talking to a doctor. And there's ways to look at this, like we can do what we call cycle mapping, where we actually test the hormone levels every other day throughout the whole cycle and kind of look at where they are in different cycles, and then pinpoint, well, I always get my symptom here on day 22 of the cycle, and let's look at where your hormones are there and see if there's some sort of imbalance. Also how you're metabolizing them. And then let's get back to lifestyle, sleep, nutrition.
Right. Yeah. And I think you answered her second question, which is hormonal therapy only recommended for those experiencing menopause? And then she says, "Oh, awesome. Thank you so much for this input." So that's why we're here, Callie. We want to answer your questions. You have the floor. You have all of this information that I'm bringing to you about women's issues that are, you may not be able to find this information from your doctor. Because as we talked about this before, Peter, not all of the obstetricians and gynecologists know this information. Can you speak a little bit to that?
Well, I always tell the story. I mean, I graduated, as you mentioned in my bio, from University of California at San Francisco pharmacy school in 2000. And so our training for menopause was every woman goes on PremPro, which was a Premarin, which is a synthetic estrogen derived from horse's urine, and a synthetic progestin. And we were taught very matter-of-factly that this was going to do all these benefits for the women. If you turn 65, you go on them and you stay on them for life. And then in 2002, right, just as I had started my career as a pharmacist, the Women's Health Initiative came out, and this was a giant clinical trial. There were two arms of it, but the two arms combined were over 25,000 women across multiple centers. It was placebo-controlled, double-blind, all that good stuff. And when they looked at the women taking PremPro, they found that they were actually doing much worse than the placebo women in significant ways, like worse outcomes with Alzheimer's disease, worse outcomes with breast cancer, worse outcomes with cardiovascular disease. Almost everything we care about in terms of long-term safety was worse, except for bone density. That was improved, but if all this other stuff's happening, you're not really so concerned about your bone density. So it caused this huge stir in the not just the medical literature, but in the newspapers, national news, and everyone got very scared of hormones at that time. And I remember, doctors telling people to throw away your PremPro, get a fan if you have hot flashes. We're not going to put you on hormones ever again. They're dangerous. And what's very unfortunate about that conclusion is that there was a lot of other evidence out there showing different ways to utilize hormones that didn't have all these problems. In fact, some of the data within the Women's Health Initiative gave us some really interesting clues about how we could be safely administering hormones to women and addressing their symptoms. But because there was this huge freak out,
yes,
we went into the hormone desert, and we're slowly coming out of that. I think even now I'm seeing more OBGYNs and general practitioners embrace hormone therapy. They're not saying just use the lowest dose for the shortest amount of time. They're starting to recognize the long-term benefits. We're still trying to get them to embrace compounding a little more and how that fits with what the other types of replacements they're using. But I feel like we've made a lot of progress, and we just had to kind of get out of that desert and get the real information back in front of people that showed that there is a safe way to do this, and there's a huge need. And I find like telling a woman who's having major hot flashes to get a fan is a bit insulting to her.
I know. I know. Oh my gosh. It's crazy. And I was going to ask you how you felt that the WHI missed the mark on that.
They really did. And what's interesting about the WHI is that there was this there were 16,000 women who got the PremPro, and there was another 9,000 women who just got the estrogen. And they didn't get the synthetic progestin that was in that 16,000 because they'd had hysterectomies. So there wasn't a concern of increased risk of endometrial cancer in those patients. And that was standard of care at that time. Now, I still think even if you've had a hysterectomy, you should go on progesterone for all the reasons I mentioned. But, that was
absolutely
standard of care. Yeah. And what was amazing is that arm of the study showed all sorts of benefits. It showed benefits with actually breast cancer reduction. It showed benefits with brain protection, the bone benefits maintained. There were some concerns about cardiovascular risk, but it was a totally different set of data that just got completely ignored in the hoopla of the release of that and everyone freaking out again. So, we still go back to that data all the time. I mean, I think there have been 200 or 300 published studies coming out of the Women's Health Initiative, looking at pieces of it that are very informative about how to safely utilize hormones. So, we should be more careful about how we interpret data sometimes. And, and think about the consequences of
Absolutely.
telling a patient that they can't use the therapy that they need, and really evaluate the risk benefit. And one of my most important jobs as somebody in this field is to just really help people feel confident and comfortable with the safety of hormones, because there's
Yes.
still a lot of misinformation around that. So,
Yes, absolutely. And aside from the hot flashes and the night sweats and all of the other menopausal symptoms that are, associated with, menopause, what exactly happens when a woman's hormone levels drop?
yeah, that's a great question, because there's really different stages of this, and I think you talk a lot about this with your other guests, which is there's like the premenopause, there's perimenopause, kind of the ups and downs, and then there's a postmenopause where
Right.
things kind of stabilize, but they kind of drop down. So there's some very predictable things that can happen, based on the research. I mean, one thing is we know that you lose a lot of the brain protection of estrogens. Estrogens are very important in kind of brain function and brain health. We lose bone density. So that's another thing. With estrogens, help preserve bone density. So we would
Right.
expect bone density to drop. Muscle strength, we expect to have some impact on that. And then the biggest symptom reported, these are kind of long-term things that may show up in years, because usually, if bone density starts to drop, you don't get into osteoporosis overnight, but
Right.
you can be tending towards that. So that's something that can happen long term. But in the short term, the most common complaint shifts from hot flashes, night sweats, and brain fog during perimenopause to vaginal dryness, painful intercourse, and urinary symptoms in the postmenopause. So again, we kind of shift our thinking about replacement to a maintaining enough level of hormones to help the brain, bone, and muscle. And if we need to address vaginal symptoms, using some targeted therapies for that as well.
Sometimes women feel like they're just falling apart, and that their bodies have just turned on them, and I say that that's not the case. It's just a new person. It's a new beginning, and it's embracing who you are on a different level, because menopause is not necessary. It's not the end of your life. It's the end of your childbearing years, and so it's not a time for women to focus on all of the physical aspects that are going on in their lives, but to focus on all of the wisdom and the wonderment and this whole new being that is manifesting right before their eyes in the mirror. And so, what I want to ask you about another study. It was a rather large long-term study in Denmark, and it found that women who took systemic hormone therapy before and during menopause had a greater risk of depression. And this study's findings were consistent whether it was whether they were taking estrogen alone or whether it was combined with progestin. Now, to be fair, the study didn't, in talking about studies, it didn't distinguish between synthetic or bioidentical hormone therapy, which leads me to ask, in your over 15 years of working with women, are you aware of any of these same findings with women in the United States?
Yeah, that is a caution with progesterone. Especially with oral progesterone. I'm familiar with that study. My my encouragement when I talk to doctors about some of this research is, you made a very important point, which is synthetic versus bioidentical. The research looking at those, and I always say it's quite different. And I always say it's like giving something to the body that's progesterone, that the body makes and understands, and giving something that's progesterone-like and expecting it to act like progesterone is a foolish thing to do, because the way the body works, especially with regard to hormones, is extraordinarily precise. So if we change the structure at all, we're going to change the activity of that hormone. And we saw that very starkly with the Women's Health Initiative. If we took out the synthetic progestin from the women's therapy, all the negative long-term side effects went away, because we weren't giving this kind of odd drug that was supposed to act like something else, but really wasn't that thing. So we say, like, that's the kind of important aspect. Like, it has to be exactly right. The other part of it that's important to talk about, and even with regard to bioidentical, is how you're delivering the hormone into the body. So like something like progesterone, oral progesterone is wonderful because it improves sleep for most women. It's highly metabolized in the liver. If you take anything that you take orally gets passed through the liver before it enters your bloodstream. And these hormones get highly metabolized. And it happens to be that progesterone is very unique in the sense that its primary metabolite kind of has some brain effects that help you be calm and help you sleep. But for patients who have a history of major depression, they tend to have what we call a paradoxical reaction. Instead of feeling calm, they either get anxious or it can trigger a depressive episode. So that's something that we want to educate doctors about. However, in that same Swedish study, or if you're referring to the one I'm thinking of, when they changed the route of administration of progesterone from oral to vaginal administration, which goes into the body without that metabolism through the liver, all those risks went away. So again, it's very precise. Our job as kind of experts in this field is to help doctors be aware of those things, do the proper intake, make sure they're evaluating the risks. So I have had some patients with histories of depression who've done very well on oral progesterone and hormone replacement, and it tends to do an excellent job of helping with mood and general experience of life in that regard. But it is just something that people should be aware of, and certainly not a reason not to consider these therapies if you have a history of depression. Just making sure that your doctor is aware of some of the risks and that you're well monitored, and probably utilizing different routes of administration.
Wow, that's fascinating. And yeah, I'm so grateful that you knew about this study. But then, hey, this is your wheelhouse. You love this sort of thing. You live for this. So I knew as soon as we connected, I knew you were the right person to speak on this. And now I've also been researching nutrition sources that ease menopausal symptoms. And I read recently that bioidentical progesterone is made from yams. And I eat a lot of yams. Should I be eating more? Or what other food choices can women take, to effectively relieve some menopausal symptoms?
Yeah, so to be clear, there's no bioidentical hormone found in any plant. So even though it's from yams, it actually still has to be modified in the lab to become human progesterone. So the yams aren't going to help you with your progesterone levels. Even though I love yams too, and it's a good healthy.
I know. So with all the yams I've been eating, I'm still having these issues. So I'm like, okay, let me ask you, the expert, what's going on here? Give me the 411.
Yeah, it's a great question. It comes up all the time because there are some supplements that may help with certain symptoms like hot flashes. There's a product called Estrogen that I think has, I remember exactly, it's like a keeper extract. There's things like Vitex that can help with some of that. But for me, there's really no substitute for the hormones themselves. I mean, the hormone replacement is not just about treating the symptoms. The symptoms are almost like the body's alarm bells going off saying, hey, I need these hormones and I'm not getting them. I have a doctor who I love, always says this to patients when they come in and they're like, oh, I've got all these terrible menopause symptoms. It's like, oh, you're so lucky because your body's telling you to get on hormones and you're going to be so grateful for this in 20, 30, 40 years. So anyway, that's probably easy for me to say, but
yeah, pretty much.
I like the idea of thinking more about holistic care. And I think that's the other great wake up call maybe for perimenopause is like, even if, you want to kind of hold off on the hormone replacement, there's lots of things you can do from a lifestyle perspective.
Even pre-menopause.
Even pre-menopause, exactly. So sometimes you don't get the wake up call until perimenopause, but anytime you do and you start to understand how your nutrition affects your experience, your sleep quality, your exercise, your stress management, then that's just a great place to start for everybody.
Yeah.
And I can give people hormones and try to do the best I can, but if they're not engaging in some of those other lifestyle, activities, it's very hard to get successful with the hormones.
Yeah, I'm so grateful that you said that because exercise is really key. I find that I have less symptoms when I'm exercising on a regular basis. Finding the trigger foods that will exacerbate those symptoms of like night sweats. It's night sweats for me, so I know what foods, if I consume them, I'm going to have an adverse effect. So it's really, really important to know your body, know what your triggers are, and also to journal about what's going on with your body. So if you're premenopause or perimenopause, you know when you're going to actually go to postmenopause, because if it's 365 days without a menstrual cycle, then you have to know when the end of those 365 days are without a cycle. If you're not paying attention to your menstrual cycle, you'll never know. You'll never have that information. Would you agree?
Absolutely. And it's great that you bring that up, because in terms of our kind of monitoring of people's hormones, the number one most important monitoring parameter is patient self-reporting of symptoms. So we find this a real challenge for some patients, where we have to start teaching them to pay attention to their body, to start feeling how they're feeling, chronicling it. And so then we can say, okay, well, you came in, you had, this level of hot flashes, and now it's this. So we can utilize that information to guide us to the appropriateness of therapy, again, with the goal of like, let's get you to 0 hot flashes, let's get you to 0 brain fog. So it's a great practice to get started at any time, and it's very helpful when we're doing the hormone replacement piece of it.
Yeah. Now, I do want to say that many African American women are really hesitant to embrace certain medical therapies because of how our healthcare concerns have historically been. They've been discounted and even discriminated against by the medical community. What would you say to these women to alleviate their caution and trepidation in considering hormone therapy?
I just really encourage any patient, African American woman, to really embrace this. I really feel like, and I think the way to look at it, so that it doesn't, I think I understand the idea of not wanting to medicalize this transition. And you kind of beautifully described how it's just a new stage of life. This is just something that to really embrace. And so the goal of this therapy isn't to medicalize it or give you a drug. This is really just to shore up those key functions in the body, so that as you're in this new stage of life, you have the highest possibility of quality of life today and 10 years down the road, 20 years down the road. And the data that we look at, I mean, it is in the populations that are studied, and a lot of times African Americans are excluded from some of those studies. But this is foundational medicine. This is hormones work at a very foundational level in the body, and we have plenty of patients of all different cultures, creeds, and races, and we know that when we're in that relationship with the patient, and we're having that conversation with you about how you're responding to the hormones, we know that we can optimize the safety and the efficacy of these therapies. So again, kind of my goal in life is to help people feel unafraid of this therapy, embrace it as a healthy aging kind of adjunct or supplement to make sure that the body has the hormone foundation it needs to maintain all those key functions and have that quality of life. So, women are living longer than ever. I don't think it's unreasonable to think you're going to live maybe a majority of your life, or at least a large chunk of your life postmenopausally. And there's no reason to think that can't be amazing years doing all the things you want to do with all the wisdom you have now. And
Yes.
with health, that's the key is you need to have health in these years. And I really feel like the hormones are a really key part of that kind of whole picture. So I'm happy to talk to anybody about that, and hopefully, this conversation has helped people, kind of demystify a little bit about some of those things as well. So
Yeah, it's extremely important to have that quality of life. If we are living longer, it's one thing to live long, but to have the quality of life along with the quantity of life, it's so very important. If you are living longer, but you are racked with disease or pain, you're not having a great quality of life. And so to have these therapies available to us to ease that discomfort is, why wouldn't you?
yeah.
And I also want to say that, women of color are known to have menopausal symptoms that last longer, and they're more intense. So,
Right.
is bioidentical hormone therapy of any particular benefit to them, and how so?
Yeah, 100%. And I know the studies that I've seen have showed that about 10% of patients will continue with hot flashes and night sweats, into postmenopause years. And I think in some studies that number is actually higher in African American women. And those are the women that we treat the most because they're coming to us saying, I don't want these symptoms. So it's absolutely appropriate to continue that same approach that you would have in perimenopause and postmenopause with the same goals of no hot flashes, no night sweats, good brain functioning. So there's kind of two things going on. There's the immediate symptom relief, and then there's the long-term benefits. And so if there's still symptoms happening in your, later postmenopausal years, we definitely want to, work with the hormone balancing to really address those. So that's absolutely what we do. And we have lots and lots of patients that we work with in that regard.
Oh, wonderful. Now, you spoke a little about this earlier, but can you elaborate on the advantages and the disadvantages of oral versus topical estrogen?
Yeah, so perfect. I'm glad you brought that up because I kind of mentioned in that estrogen only piece of the Women's Health Initiative that there were still cardiovascular risks. And so when they did a deep dive into that, what was really fascinating was that the cardiovascular risks were seen when people initiated the therapy later. And the thought process was that estrogens actually are protective of your cardiovascular system. But when you take estrogens orally, they increase the mobilization of clotting factors from the liver. So if a patient has a degree of atherosclerosis and heart disease, the clotting effects of oral estrogens take over and there's an increased risk. But if the patient's younger and they don't have any progressive heart disease at that stage, then the protective effects were taking over in that study. So then what the researcher says, well, let's look at what if we give the estrogens topically, so we don't have it go through the liver like the oral progesterone and have it have all this effect with increasing clotting factors. And what they discovered was that when you give the estrogens topically, that cardiovascular risk goes away at all ages. So you're going to get the beneficial effects younger and older patients because it's not mobilizing the clotting factors in the liver. So this is one of those other things too that's like, oh, there's a certain age that you can't start hormones. Well, certainly there's a certain age I wouldn't start something on oral estrogen, but certainly the research shows that especially for a healthy person that doesn't have any evidence of cardiovascular disease, you still can get cardiovascular benefits starting later in the postmenopausal years, and be safe with that and not have increased risk of cardiovascular incidents. So it's interesting. So again, kind of getting very specific about which hormone we're using, how we're delivering it, what's the age of the patient. And it's not rocket science, but it's just these special considerations that, we want to make sure we're paying attention to so we get that perfect regimen for everybody.
Yeah, because there's been some conflicting information out there about what age and what's going on with younger women. Should they take it? What older women? No, they shouldn't have it. And you're afraid to take it because you don't want heart disease, you don't want to break a bone, you don't, all of these different concerns. And so, and then there are people who are saying, or doctors, I should say, some doctors who are saying, well, it's okay, the number is just arbitrary, and so don't worry about the number as long as you're healthy. And so you begin to wonder, and you can understand why some women are just confused and don't understand, and just throw their hands up and say, "Oh, what the heck? Forget it. I'm not going to do anything."
Yeah, I find that sad that that's what happens, because and also the doctors will say something like, "Well, I don't really know if this causes breast cancer, but just to be safe, we're going to not give it to you." Well, first of all, there's no evidence that these hormones cause breast cancer anywhere in the literature, anywhere. So, first of all, once you mention that to any patient, they're going to be scared to use it, right? That's just a scary thing to say. And this idea that, like, well, just to be safe, I'm going to deny you this therapy that you will benefit from, is actually a kind of harm. So it's very unfortunate to me that because there's so much confusion, because allopathic doctors are still not really well educated about some of the stuff we're talking about here, about the difference between oral and transdermal and bioidentical and synthetic and all this stuff, that they're still telling patients stuff that's scaring them about utilizing hormones, when we should be encouraging women to embrace this therapy if it's appropriate for them, and if this is something that they want to continue with a ton of confidence that it's safe, that if we do this appropriately, it's going to help me a lot, and get, no more throwing your hands up. This is okay. And we just haven't gotten there yet, but we're trying. We're
getting there. You're getting there. Yeah. And I think that the more women have this conversation, and they put their doctors on notice and let them know, listen, you've got to tell me what's going on, then there's more research, and they're more open to pursuing these types of therapies. Years and years ago, I came in contact with a woman, and this was probably during the WHI period, where she stopped the hormone replacement therapy, and her menopausal symptoms came rushing back. Is it advisable, when actually is it advisable for a woman to stop hormone therapy, and is that indicative of the majority of women that will have those symptoms come back, or what's going on with that?
Yeah, I think in the midst of the perimenopausal stage, that's not a typical, you're going to go back to the fluctuations and all the consequences of that. So post-menopause, it's less likely that those symptoms would come back, except some of the vaginal symptoms that I had mentioned earlier. I'm trying to make a case to women that it's something that you can safely use for a long time. And of course, I get the question, do I have to do this for the rest of my life? Which just seems like a very daunting thing to tell somebody. And I just say, you don't have to do anything you don't want to do. I'm just going to try to present you with the best evidence I have. And I think also, I want you to experience what it's like to be on the hormones. Do you feel like you're getting benefits from it? And certainly for patients who have things like, osteopenia or other types of long-term symptoms too, are you able to monitor, are we slowing down the bone loss with this? There's some ways to kind of quantify, the benefits of this. And I'll tell you, most of our patients, they don't want to go off of it. They're like, they feel like it gives them tremendous benefit. I have patients in their 60s, 70s, 80s, and even 90s on hormones. And of course, we're monitoring them carefully and making sure that we're doing it safely. But they're choosing to stay on it. And I think that's really the answer I give to patients, is that this is your choice. We just want to partner with you and kind of help you feel confident that this may be appropriate for you. And,
So if a woman is, let's say a woman is over 60 and she has not had the hormone replacement therapy, and she's been, she's had hot flashes, night sweats, or whatever for over 10 years. Would she be eligible to have hormone replacement therapy or bioidentical hormone therapy?
in my opinion, 100% yes.
Mm-hmm.
That would be a person I would absolutely try to get into, see a doctor to discuss hormone replacement, because that's really the best option for those types of symptoms at any age,
Mm-hmm.
not just the perimenopausal ages. So yeah,
Even
absolutely.
if she had some health issues, like
Yeah,
maybe.
and there, yeah, that's where the doctor needs to do a thorough intake and look at whatever health issues they're having. I mean, certainly there would be lots of things to look at in terms of that age that we would want to take a look at. But there's nothing that would say, oh, absolutely not. We would never give anyone at this age hormones. There's no age cutoff. It actually doesn't really make any sense that there would be an age cutoff. That seems very arbitrary to me. And I do know that for the symptoms you mentioned, hormone replacement is the best treatment. And we're going to get resolution of those symptoms and ideally some of these long-term benefits as well.
And so what are some, so let's say this woman is like, she's watching us today and she says, I think I want to try this therapy. What would be some of the questions that she would ask of her gynecologist?
Yeah, that's a very good question. And I think gynecologists are starting to come around on some of this. So I think the first question is, what's your comfort level for putting me on some hormone replacement at my age? And if the doctor looks very scared and starts sweating, he might not be the best doctor to help you with this. So, it's unfortunate. We're trying to work with as many OBGYNs as we can to help them feel comfortable, because I think they feel a lot of the same fears that your patients. They throw up their hands and say, I don't know, so I'm just not going to do it because I don't want to risk my license or something like that.
I guess that is a concern.
Yeah, it is. And they weren't, just like me, they weren't taught this stuff in medical school. So this is all new. It's a very different approach. It's very holistic. It integrates a lot of things like nutrition and stuff that's not really in their wheelhouse. So it's a good place to start if they just really are giving you, a very kind of straight arm, like, I don't want to talk about it, or I don't want to, you're too old or anything like that. I just think it means that you need to find somebody else to help you with your hormones, and ideally somebody who's experienced, so that they can help you work through your medical conditions and any other concerns you have. So
possibly having a naturopathic physician and a gynecologist and a primary care physician.
Probably. Yeah, that's probably right.
Yeah, I mean, that sounds like what it would be, because if there are gynecologists who are not necessarily receptive or don't have the education, and that's not to say that they're not educated, but they don't have the knowledge base that someone like you has, it would be beneficial to not only talk to someone like you, but also to have a naturopathic physician that is available to support them. And you do that. You work with not only doctors, but also naturopathic physicians. And so talk a little bit about that and what the process would be. So if a woman is like, okay, where do I begin? Right. Where does she begin?
Yeah. Well, one of my favorite parts about my job is that I get to talk to a lot of doctors about their patients. And so, when we go to doctors' offices, one of the key things we try to leave them with is that I'm available all the time if you have a difficult case, especially in the hormone world, but in all sorts of different ways. And, if it's an OBGYN and they're, well, I'm open to it, I just don't know enough, I would love to talk to that person, because I'm really trying to have these kind of conversations with doctors, because we expect a lot of our doctors to know everything and they just don't.
Right.
And that's a reasonable expectation to begin with. And I know a lot of really great OBGYNs and they're doing what they were trained to do, but this is all new for them. So all I ask is for just a willingness to have this conversation with me and present some of the evidence and get them a little less resistant to it, and maybe clear the air with them. But that's also true with naturopathic doctors. they have a very different approach to medicine where it's more holistic, and maybe they'll use some nutritional and supplements and things like that. But in California, naturopaths can prescribe hormones. So for a lot of them, I'm training them. I say, well, let's talk about your cases and talk about, what you want to look for, and, talk about progesterone and, depression and things like that. So that's really a lot of what we do, depending on kind of where they're coming from. So yeah, if your doctor is willing to have a conversation with me, that would be a wonderful outcome of this conversation we're having, because we just want to spread this information.
Absolutely.
And get more women the opportunity to be on this therapy if it's appropriate for them. And we just think there's a lot of people who need this, who aren't getting it because the confusion, the fear, the lack of access to a doctor who's going to help them with it. So.
Yeah. Now that brings up another question. Do you see individual patients, or would they have to get a referral to speak with you, or what? How does that work?
Yeah, I don't at this time. I don't have somebody that I just refer to our network of doctors that we work with, and then I consult with the doctor. So I'm really my consultation is really directly with the doctor. I don't prescribe the medications. We just get the prescription in and then work with the patient once that prescription's come in. So we do have on our website a referral list of doctors that we work with. So that would be a good place to start to look. Now, are they only in the California, Northern California area, or do you have a network across the United States? Our network is all within California. We do have some North and Southern California. We do not dispense outside of the state. So all of our network is within California.
Okay. And what about people who are outside of California? What would you suggest they do?
The best thing to do is call your local compounding pharmacy, because I guarantee they're working in the hormone space. This is a really big piece of most of our businesses in this type of pharmacy, and I bet they have some good referrals for you. I mean, of course, always you're Googling something bioidentical doctor. You're going to get a lot of sometimes very slick presentations that maybe have some very costly options, but I always like a direct referral from somebody who's kind of knows those doctors. And I will say too, like, even if you come to our site and look for some referrals, it's always about the relationship and the fit. So even if somebody comes to me and says, tell me the best doctor, I'm like, there is no best doctor. There's only the best doctor for you. So I'm going to give you 3 names. And I want you to call all 3, and one of them is going to be the one that you want to work with. And I don't know who that is, because it has to be that right feeling with them. So it's a good idea to kind of call a few. Most of them will do, especially like the naturopaths and the ones that are cash pay, will do 15-minute consults, and you can kind of get a sense of their approach and their knowledge. So that's a really good thing to do. It takes a little bit of work and research, but it's time well spent.
Yeah. And now you brought up, actually, there's another question. So bioidentical therapy, is that covered by insurance, or no? Is that out of pocket?
Unfortunately, the compounded stuff is almost never covered. It used to be back in the days, and they've just stripped that away. Most plans don't cover it, unfortunately, anymore. Some of the commercial items are, so it really just depends on your plan. So I do have some patients who, for financial reasons, had to move to a bioidentical option that came from their CVS because it was a $5 copay. So that's another conversation to have with your doctor. We do everything we can to make these affordable. And by maybe giving you a 3-month supply at a time and kind of trying to get some of the costs down. So I still think they're affordable if you get them through a compounding pharmacy, but there's ways to do these through the insurance pay, but it's probably going to be a more manufactured option for the most part. Got
you. Oh my gosh. This has been such an amazing conversation, Peter. I am so grateful for you. Oh my goodness. It's been a pleasure and a joy. I'm telling you. Thank you so much for joining me. And I appreciate your generosity of your time. I really, really do. If anyone wants to connect with you on any level, how could they do so?
Probably the best way to reach out to me personally is just by email. It's just peter@koshlandfarm.com.
Can you say that again?
Peter, my first name, at Koshland Farm, KOSHLANDPHARM.com. And our website with that referral list is just www.koshlandfarm.com. So those are good ways to reach out to me. So yeah.
Great. And I will add that to the description. And if anyone wants to contact you, because you are so open, and it's just been a joy to speak with you. And I'm giddy with the fact that you're speaking to us on our level.
Well, having the opportunity to speak to you is incredible for me, and just being so open to asking these great questions and helping women understand some of this stuff is really really important to me too. So it's a win-win situation, and I'm grateful right back at you to ask to speak to you. So
Yes, thank you so much. It has definitely been a pleasure. And so now for you back, it's just thank you for joining me today. I am sending you all a virtual hug. If you want to see more content like this, please click the subscribe and the bell to be notified when we post a new video. And if you have a topic that you'd like for me to address, feel free to leave a comment and let me know. I love to do this and to research topics that are of greater interest to us in this community. And so with that, I say see you soon, and always remember, it's your life. Live it well.